Later, periosteum microcirculation it acts as an incentive. Impulse, stimulated. Hello everyone, myself Dr. Ankit Arora, and in today's lecture we are about to learn about implants that will be done using piezo surgery. I am a maxillofacial surgeon from Premium Institute of India, that is 𝐴IMS New Delhi, and I have there 7 years, and I have learned various degrees of surgical procedure regarding piezo surgery. And in today's lecture, we'll be learning about the piezo surgery and its application in implantology. Today's lecture is dedicated to my alma mater, and here we have learned, and as I have already discussed, this is a huge team, and we all learn, live the implantology. I have no conflict of interest, nothing to declare that you should buy this piezotome or this piezotome. I am only here to explain and share my experience of implantology with you. Okay, so let's start. And if in case of uh, I'm getting messages that there's no audio. Am I audible? Kindly write in the chat. Am I audible or not? Okay, okay. So let's start. That I have no conflict of interest. Now, in the previous lecture from introduction to surgery, which was done on 20th of March, we understood how piezotome works. what are the tips that are involved, what are the phenomena by which piezotome cuts the bone, and the principle by which we can obtain a greater precision and a bloodless field. This is how we can learn the basics of piezotome, right? And at the same point of time, in today's lecture we'll be discussing regarding the piezosurgery application in implantology, that is rich split, when the nerve lateralization or the bone contouring before or prior to the implantology. We will be seeing them in case we'll be reviewing the literature, and at the same point of time we'll learn one point or the other, so that at the end of the lecture there should be one or two takeaway points where your practice in clinical implantology should improve, though by a percentage, but still I think if I am able to contribute that small percentage by today's lecture, I'll be more than happy. Now, no. And in the coming lecture, the on 3rd of April, we'll be discussing regarding the sinus lift simplified, that how we can do the sinuses surgery, the direct sinus lift or the indirect sinus lift, then accordingly, and how the piezotome helps in doing and simplifying these complicated sinus lift surgeries. We'll be obviously doing understanding and doing the things in the coming lecture on 3rd of April, right? And the lastly, the different application of piezotome, that is on 3rd of April, the 10th of April, we'll be discussing that. Okay, now considering the today's agenda, that is the implantology, we'll be dividing them as per the uses of piezotome into three halves. Though there are many applications, but I have considered them to be included in 1 hour lecture, so that we can focus them, study them, and detail them out, so that we'll be able to do the procedure if at all required in our clinical practice, right? So the rich split, in it will be reading about how are we going to prepare the implant, or considering the buccal bone thickness, how a buccal bone thickness, or the I would say the attached gingival thickness on the peripheral of the implant, that is on the buccal side, as well as the palatal mesial and distal side, how the bone thickness govern the thickness of the attached gingiva circumferentially around the implant, going to play an important role, and how we can use that principle, and how we can use that principle to do the surgery using piezotome, and obviously and seeing the cases, and then we'll be seeing at the end of the 4-year follow-up, considering the bone loss or the attached gingiva thickness in and around that, and after that we'll be understanding and taking the experiences of other doctors, right? Other doctors, right? So that and then review of literature. Considering the bone contouring, we will understand that regarding the bone contouring, we will understand where are the indications of bone contouring in implant or before the implant surgeries, and the preparation of osteotomy. How are we going to prepare the osteotomy in such conditions? And then the placements of implants, so that we can understand the principles of bone contouring using piezotome. What are the steps involved? How much should we do? And are we going to how do we are we going to contour the bone prior to the implant positioning? And the nerve lateralization. This we will be discussing at the end of this presentation, and in that we will be discussing regarding the indication where the nerve need to be lateralized, right? What are the position of the lateralization, placement of an implant, and at the same point of time placing the graft, as well as the uh, barrier membrane, so that the it allow the tissue to be grown in a selective direction. That is why it is known as GBR, that is guided bone regeneration, right? So in such scenario, we will be discussing them in the coming lectures, right? Now let's discuss the case one, that is the controlled split crest and guided bone regeneration with contemporary implant placement, right? So what we'll be discussing in this case would be ridge split. That ridge split is the splitting the bone and expanding it with a technique that will allow the bone to be manipulated, right? that will allow the bone to be manipulated in a form that native bone receives the implant without removing any bone from the implant site. Okay, that is the ridge splitting, right? That is known as the ridge split. Okay, we'll be discussing them in the coming slides with photographs and videos, so that you'll be able to understand it in a easy and a crisp manner, right? So this technique, basically the ridge split, it relies upon the healing potential of the spongy bone. Basically, ridge split is more favorable in maxilla because of the sponginess of the maxillary bone, and at the same point of time, it allow the cortication of the maxilla, and it allow the bone to be pliable, right? To be pliable, right? So it and it helps to preserve the periosteum, right? Now, many of us are more used to putting an implant in the anterior maxilla or anterior mandible, and they found that whenever the buccal bone thickness is less, this approach limits the risk of fenestration, dehiscence, or necrosis of the buccal bone during implant insertion and healing. This is the time when I don't have that pisotome, and I used to put implant and do the buccal bone grafting. And at this point of time, what happened is I was encountering many cases where the buccal bone fenestration and dehiscence, they are very much frequent in my anterior implantology cases. So when I review the literature, and at the one point of time when I started using pisotome, I would say that uh, Pisotome allows the buccal and the parietal shelves to be separated on your will, and allow the implant to be fixed in a relatively passive and a predictable position. Okay, let's see them. And let's in a Boozer, he's a very renowned implantologist. He says that a survival rate of implant when placed in sites augmented with a split crest technique, it ranges from 86 to 97%. That is more than 85, 86 to 97%. 97%, they survive after 12 months to 5 years, right? So in such cases, it is very much frequent. It is very much imperative that we rather use ridge split technique in comparison to the GBR technique, right? So let's go and understand the scan uh, one by one, right? So in that case, what happened is we see an axial section, and we found that the implant at the crest implant that the bone at the crest was very less. It's around 1.3 mm, and when we go around 5 mm down the crest, we found the bone around 2.4 mm. And as we go further, we found that the medullary canal bone, it increases in thickness, though the most advantageous position was it is around 11.5 mm. And in the region of I would say 2-1, that is the left upper central incisor, we have a bone length of only 10 mm. So we were there regarding the 12 mm, around 11.5 mm implant height in the region of lateral incisor. And when we go for the left central incisor, we found a bone thickness of around 9.7 mm, right? So when we see it axially, now you can see the case. When we see it axially, you can see the very less bone in the region of 2-1, 2-2, and 2-3. So in such region, so ideally, what need to be understood is that we should carefully look upon the thickness of the bone for placement of implant, right? So now there's a very good conference, good team of implantology that is working in and around the world. Go by the name of ITI, that is International Team for Implantology, and it has a consensus conference in 2004. It is worth remembering that the buccal aspect you can see in this I would say diagram in this diagram, that the buccal aspect or the implant neck, it should be 1 to 2 mm from the buccal margin, right? if we draw a line from the buccal surface of the adjacent teeth, and whenever and wherever they meet, our implant should be around 1 to 2 mm from the tangent line. This is the dimension. This is the what you call a protocol. This is the protocol which they have derived, and they have come to a conclusion and the consensus that it should be done on a regular basis, right? So this is the pre-operative picture of the same case, and this is before giving the incision, and the incision was given slightly palatally, so that in a near future, whenever we have the thickness of the attached keratinized gingiva in and around the implant, it has proven to be more helpful in increasing the implant health. Okay, more helpful in increasing the implant health. Okay, so such in such scenario, the attached gingiva thickness should be preserved at every point of time, right? Now you can see the piezotome tips. These are the piezotome tips and the alveolar crest level, which was not proper. It was properly contoured to a stable, uniform height. Okay, so that both the implants are at the same abutment level, right? So in such scenario, we need to consider, we need to understand that it should be properly better. Okay, and this is after we done the crest the ridge split, and the main advantage of using the ridge split is technique using piezotome is you can calibrate, you can go as per the desired length of your insert tip. What are insert tips? Insert tips are the tips that goes and that goes into the ridge as per your calibration. You can see the margins, right? You can see the margins, and these margins are of 8 mm, 10 mm, and 12 mm. So as we have already calibrated that, we need to go till 11.5 mm till the nasal floor in the 2-3 region, in the left upper canine region. So you can see in the ridge split area, we have taken a proper diagram, and we have gone till the 11 mm thickness, 11 mm height. So in such scenario, we need to understand that these things are very helpful in understanding the implantology and doing the implantology in delicate cases like this. Okay, and the most important advantages of piezotome you in such scenarios are the constant irrigation in conjugation with cavitation phenomena. It reduces the risk of bone necrosis. It otherwise it would not have been possible with other conventional methods, where the bone necrosis or the spillage of the bone or the reduction of the bone would have happened in no time. So in such scenario, the piezotome is very helpful, and rather I would say piezoelectric bone cutting, it does not influence the bone remodeling or cell viability. It do not influence the bone remodeling, right? And I would say in the coming slides, you can still see the blood proper circulation in the splitted crest, and in the diagram rightly on the in the diagram on the left, you can see the split as per the diagram, and accordingly we can see in this clinical picture where we have gone into the crest in the undivided bone, right? In the undivided bone, and in that undivided bone, which is now being seen in this arrow, we need to engage our implants. Okay, we need to engage our implant. So in such scenario, we need to properly engage it, right? So uh, one of the most important thing regarding the regarding the piezoelectric unit is it allows the better microcirculation in the periosteum and the bone, and this microcirculation alone, it acts as a incentive for the bone metabolism to happen. It allows the, I would say, the bone to remodel, and more concentration of the osteoblast, more concentration of the less presence of inflammatory cytokines that will induce the bone resorption. So as a result of which, I would say piezoelectric device, it stimulates the peri-implant osteogenesis, which is very much required in such cases, and the reduction of pro-inflammatory cytokines like IL-7 or IL-2, right? After placement of after placement of the first drills, we put an paralleling pin. You can see it from the occlusal level or the buccal aspect. You can see it that the paralleling pins, they are exactly in the crest which we have divided, which you have seen it properly, right? So, and after that we confirmed it with a radiograph. Okay, we confirmed it with a radiograph, and after confirming it with a radiograph, we proceed to the another level, and we completed the osteotomy. And we after completing the osteotomy, we pliable the buccal as well as the little bit of palatal bone. Though palatal bone is resistant to splitting, but at the same point of time, the buccal bone, we should not make it more pliable. But at the same point of time, if we can slowly manipulate it to improve quality. What do you mean by improving the quality? If we are using the piezotome, then in such scenario, the compaction and corticalization is done at the same point of time. You can either use the densaber, or at the same point of time, when you use the piezotome 2 mm bar, which we will be seeing uh, in our coming cases, that how you can use it, how you can use it in your cases, right? And after that, we place our implant, considering we place our implant in the buccal and the in the shelf that is created in the buccal and the palatal shelf. And after placing the implant, we deliberately put it 2 mm below the alveolar crest, considering that the buccal bone as well as the I would say mesial and the distal bone, they tend to loosen. They tend to get loosen over a period of time. So for in that scenario, we uh, put it 2 mm deliberately uh, below the alveolar crest. And the most important thing that we need to consider in our implantology practice is the cortical plates of the residual ridge. They should be carefully splitted, considering if we maintain periosteum attachment at all levels on the buccal side, that is in the either in the apical third or the middle third or the crested one third. Because if we maintain attached periosteum, it is very much critical to the formation of the new bones around the interproximal surface of the implant, that is peri-implant osteogenesis. It becomes very much predictable, considering the ecosystem is there, and it is very helpful for the implant bone formation to occur, right? Now coming to the review of literature, this Vasiloti in the year 2000, he says that if we treat the sites treated with bios and or bios collagen, it obtain more bone to implant contact, that is known as BIC. And if we packed it with a graft and covering that whole unit with a collagen membrane, and in that area if we see the marginal bone loss is very less, or that is the marginal bone loss values, they are very less at the control site at the end of 2 to 3 months, right? So following this article, we place our implant 2 mm subcrestal. We put a graft there and put a collagen membrane, and at the same point of time, we were knowing the simple fact that the bone expansion that is occurring, it should allow the condensation of the softer bone quality that is present at the apical region, which we have seen in our previous lecture, to be more condensed variety apical and lateral to the prepared osteotomy. So in such scenario, it is possible only with the help of only with the help of a piezotope, right? So, what will happen to this intra-bony gap? This intra-bony gap will be initially filled by a blood clot, and at the and what we have studied in our physiology classes, that the end of the blood clot in a bony marrow region, it will in itself will turn into an osteoid tissue in about 40 days. Okay, it will convert into osteoid tissue or the bone formation in about 40 days. And after 3 to 4 months, that is 90 to 120 days, that extracellular matrix progressively mineralizes and osteoblast mature into osteocytes. So that is what which we were seeing, that uh, it basically allows, the peri-implant osteogenesis, right? It basically allows the peri-implant osteogenesis, and it is possible because of the better periosteum microcirculation. And if we go backwards, we'll see that better periosteum microcirculation is feasible only because of the I would say formation of the intrabony gap, which is done with the help of a piezotrope, right? Now, this is what we see after 6 months. These are the placement of the impression copings, right? You can appreciate the condensation of the attached gingiva there, and obviously, and this is how it looks like from the frontal aspect. And these are the placement of zictrials, right? And these are the after impression coupling, we did a zik trial, and we fixed and we confirm it from other aspect that we are doing it. Okay, and this is the photographs of the impression coupling from the occlusal aspect, so that we do not do a mistake of in our impression, and deliver our prosthesis at in every correct manner. Now this is our 6 months follow-up phase. Okay, 6 months, when we see it after 6 months, just before loading, right? We properly waited for 6 months for proper osseointegration phase in this photograph. And what we noted is there is an implant, there's a circumferential bone loss in and around the implant for about 1 to 1.5 mm in the implant in the lateral incisor region, and in the canine region we appreciated around 2 bone loss, only on the mesial aspect, right? So obviously we learn from our mistakes and all. So what we make sure that there should not be any premature contacts in the prosthesis, and we follow it up closely, so that we should not have any peri-implantitis or ultimately implant failure. And what we appreciated is, and we studied from our literature that Amra, what she has said, that if a 1.5 bone loss has happened, or in fact less than that, and subsequent bone level changes of 0.2 at the implant and the bony interface, they are basically and generally accepted as within the limits of a normal physiological process. Okay, as a normal physiological process. So going by these literature, if we follow our implant case properly, maintaining the proper oral hygiene, and promoting or telling the patient to take proper steps to maintain his oral hygiene. At the same point of time, we are monitoring the health of the attached gingiva, which is very much crucial nowadays regarding the number of implants that are being placed. If we can maintain it to a proper level, then we can obviously win in any situation. Now, this is how it is after 4 years of follow-up. Okay, and what we have seen is there is a stable bone level in and around the implant, uh, and we do not we do not consider, I would say, we do not see increased bone loss in the implants. And obviously we are following the case properly. We follow up them in every 4 to 6 months, and at the same point of time we influence the patient, we promote the patient for better oral hygiene, so that uh, uh, once an oral hygiene is proper, obviously we are very much sure that the initiation of the periimplantitis is arrested or is checked at first step only, right? Now you can see these both things are comparable in both 6 months to 4 years follow-up phase, right? Now you can see this is the photograph of 4 years follow-up, and you can see the thickness of the attached gingiva. Though we know that the prosthesis, it is not that much, but we make sure that it do not have premature contact. So okay, and bone expansion, it allows have to reduce any labial undercut, and it obviously allows more favorable axial loading. Hence, the with the presence of with the help of a piezotome, we also make sure that we do not put our prosthesis under more unfavorable axial loading. Now, this is how the implant in a diagram will look like, and we can see if we can control our gingival health to a better level, then obviously we can win from any situation. Everything. Let us see this case. Let us see this case in a form of a video, right? Okay, so this is the deficient maxillary ridge, anterior maxillary ridge, right? Which we have seen in our diagram, right? And no, we can see the thinness and thickness of the alveolar crest bone in all the sections, that is 1.3 mm in the startings, right? And 2.4 mm in the region where 5 mm, when we go 5 mm apically, right? This is the axial section that shows the complete thinned out buccal cortex. You can see it here. Okay, you can see in this region that the buccal cortex is completely thinned out. Okay, the buccal cortex is completely thinned out in this area, right? Now, this is the diagram which you have already seen in our slides, and this is the preoperative, and this is how we have leveled the stable and make a stable and leveled occlusal table. This is how we have done it with a proper burr, and we properly leveled it where our implant to be placed, so that implants are at proper abutment level, so that the prosthesis and the circumferential implant abutment height, it should be proper bone implant contact should be there, and at the same point of time the axial loading should be uniform in both the implants. Axial loading should be uniform in both the implant regions, right? So, and you can see the cavitation principle where, it is absolutely bloodless, and it allows the blood vessels to be informed. And after in this section of the video, you can see that how we have splitted the crest from the buccal and the parietal aspect. It was pencil shaped buccal aspect, and this is after splitting the ridge. Okay, this is after splitting the ridge, and we have gone around 10 mm in the canine region and 8 mm around the lateral incision. Okay, you can see, and we have already see the photographs in our slide, and so, we complete the split till the desired length. Okay, we complete the split till the desired length, right? Now you can see it here, and this is how after the completion of the split it looks like, and this is how this is seen. Okay, now this is after placement of the paralleling pin which we have placed, and which you have seen it in the coming slide, and then we confirmed it, and we confirmed it with the radiograph, right? And now we completed the ocular osteotomy, and we make sure that we are putting it in the maxilla and the anterior maxilla where bone is of D3 quality. And at the same point of time, what we noted is, if we drill the osteotomy short, one drill short of a final fixture diagram, one drill short, then obviously we'll get a proper implant stability in the form of torque. We'll have a good fixation with the implant, and obviously we'll have a good bone implant contact in and around the implants, right? Okay, this is how the osteotomy is finished, and the final osteotomy, you can very well see that we have preserved the buccal cortex. Okay, we have preserved the buccal cortex, and after finishing the osteotomy, okay, after completion in the osteotomy, we make sure that the osteotomy is completed, right? Okay. So placement of the final fixture with 2 mm subcrestal of the buccal bone, we make sure that, and this is how we confirm it with a radiograph, right? This is how we confirm it with a radiograph, right? Okay. Now we have seen one clinical application of piezotome in the split cases, and it is very helpful in doing cases. Otherwise, or it would not have been possible with other conventional instruments. So in such scenario, what we need to do is we need to use piezotome, because as we have already understood that it reduces the chances of bone necrosis. It allows the bone to be formed properly in and around the implant. And at the same point of time, you can also understood that though the surgical procedure has caused the marginal bone loss to occur in the first year, but what we appreciated in and around after the 3 to 4 years of the time period, that bone loss level was stable. Okay, the bone loss level was uh, okay. You can bone loss level was relatively stable. Okay, bone loss level was relatively stable uh, after 4 years of the surgery, right? Okay, so let us move on to the other slides, right? The bone contouring, that is, whenever, though we have already seen it, though we have already seen it in our cases, right? So what happened is, in our scenario is that this is a pre-operative radiograph, where the bone loss, where you can see the lingual side is there. Okay, and the bone is not uniform, right? Okay, you can see it here. You can see the bone level is not uniform. It is more on the lingual side. And if you put an R implant in that region, and then in such scenario, what happen is, in such scenario, that implant level is not uniform. Okay, implant level is not uniform, if at all it is put in such scenario. So what we do is, we take our rounded bar, which we have already seen in our previous diagram or previous sections or previous cases. Similarly, we will be doing it in the cases of bone contouring. And after doing the bone contouring, this is the leveler bone. Whatever rounding off which we have seen, and which we are done with that round bar, still we can level it up, so that we have a stable fixture, a stable bone around the fixture to be placed around the future fixtures. So in such scenario, we need to make sure that we have done bone leveling in and around the implants, right? So you can level it up, you can properly level it. Okay, you can understand it, you can see that both the bone leveling is done on the both the lingual and the buccal aspects, right? And in the both in and around circumferentially, I would say the leveler of the placement of the leveler is done. And hence what we see will now would be the uniform margins, surgical bone margins, and the leveling of the bone in all the section. Now you can appreciate that the advantage of physiotome in such scenarios. Now, basically, the best advantage I would say is the structure of the surgical bone margin. They are very much uniform, I would say. They are very much atraumatic to the soft tissues. And the bone margins, they are less impaired by this technique if we compared with the conventional burrs. Okay, and the most important, I would say, the advantage is you can reduce the bone level to thickness or the proximity as per your choice. If you want to reduce point 0.1 or point 0.2 mm, that is also possible with the piezotome, which would not have been possible with other conventional positions, right? With other conventional positions. Now you can see the fixture position. Okay, and fixture position in such scenario, you can see the in and around the bone around the fixture osteotomy sites. And this is how the placement of the fixture was done. And now we can see the uniform fixture of the uniform bony surrounding in and around the implants that are placed, right? So now we can appreciate the proper uniformity of the bone in and around the implant, and that will allow the fixture to be placed. And the implants, they are very much stable, having a good torque of 40 45 newton torque, right? So let us go to the other case. Let us go to the other case where we'll be seeing the nerve lateralization. Though the nerve lateralization it has its own indications and processes. So in such scenario, what we need to understand is you can see the nerve lateralization, right? The nerve lateralization is where you do not have the proximity of the nerve. You do not have you do not have the position of the implant to be placed because of the proximity of the nerve in very close aspect of the implants, right? So in such scenario, you need to do the nerve lateralization. What we do in such scenario is we do the osteotomy in and around the mental foramen, right? And when we do the osteotomy, we try to distalize the mental foramen where its actual anatomical location is. So what we see in this clinical scenario is patient want immediate prosthesis, right? Patient was out from around 6 to 7 decades of age, right? And at the same point of time, what patient wanted is the placement of an implant. But when we did a scan, what we appreciated is that the placement of the implant would not have been possible if at all the nerve is very much in close proximation with the alveolar crest. That is, only 2 to 3 approximation was there. So what we did is we distalized the nerve, and at the same point of time, what we understand is its approximation of the implant to the nerve should be properly monitored at the same position, should be maintained at the same position, because of the fact that other complications like neurosensory deficit that might range from grade 1 to grade 4, or other motor sensory supply, which is though rare when we deal with sensory nerve like mental nerve, might happen when we do the distalization of the nerve. So let us discuss that literature again. Uh, that this is what the diagram of uh, the distalization would look like. What happened in such scenario is that this is the mental foramen, right? You can see it here. This is the mental foramen, and what we basically do is, and this mental foramen is there's a neurovascular bundle that goes in with the named by inferior alveolar neurovascular bundle, and this foramen is mental foramen. So what we basically do is we cut a trough in and around the nerve with the help of a piezotome, right? And with the help of that piezotome, what we basically did is we distalized the nerve away from the site where we are going to put our implant. Okay, let us see this in a clinical scenario, that how this is going to happen. Okay. Now we can see it here. This is the patient, and where of about 62 years old, and what he wanted, the patient chief complaint was patient was unable to eat from both the sides, but on the left side, patient has sufficient alveolar crest, but due to the traumatic extraction that has happened around 15 to 20 years back, around 2005 to 2007, due to which the alveolar crest was very less in quantity, and as a result, what happened is, as a result of which, due to decrease or deficiency in the height and I would say the length of the bone, there was a difficulty in putting the implant. So what we noted is we opened the flap using a crestal incision, triangular flap we opened, and what we noted is when we wha- what we noted is when we dissected it, the nerve, and we noted the two bundles of the inferior alveolar nerve that that is coming from the mental foramen, right? So in such scenario is Okay, that in such scenario is uh, okay. So what we need to know is uh, we after doing the mental nerve distalization, we slowly and progressively increase our length. Okay, that is what I was discussing in the previous case. You can at any point of time you can use piezotope in drilling the implant. And there was a question also which was asked from the participant in the previous lecture. Can we drill the osteotomy from the piezotope? The answer is yes. And the good thing is you are very much sure that at which length you want to cut. Okay, at which length you want to drill, because of this simple fact that this osteotomy is done by the piezoelectric device. As I have already discussed, it stimulates the peri-implant osteogenesis and a reduction of pro-inflammatory cytokines. And at the same point of time, what we have noted is that the good concentration of osteoblasts is noted circumferentially in the bone, just approximate to the implant, right? So we can successfully claim, I won't say claim, but we can successfully say that better periosteum microcirculation, it act as an incentive for an enhanced bone formation, right? And rather, I would say it do not reduces the cell necrosis. It do not allow the bone to be necrosed, right. So, and rather in such scenario, what happened is, I would say, now you can see the initial drill and the arrow which is being demarcated. uh, it shows the current position of the inferior alveolar nerve, and this whole dark shadow shows the previous mental foramen location, right. Now the nerve has been distalized as per our I would say implant length and depth. And at the same point of time, what we can do is, we can put our implant there. And the very, I would say, very clear cut advantage of piezotome over other conventional uh, burrs and techniques and other saws is that use of piezoelectric, I would say, is a safer option, because we know in such scenarios where nerve need to be disliked, even slight movement of patient here and there can lead to iatrogenic spilling or iatrogenic slipping of our instrument, and serious complication which I have already discussed, that might result from neurosensory deficit from grade 1 to grade 4 might occur, and inferior alveolar nerve might get damaged. Okay, so what we want is, we want a free and clear access to the nerve that's desirable. So in such scenario, we need to be uh, very much clear, right? So in fact, studies have shown, what they have shown is that the negative side effects, they become very much higher if a rotating instrument it comes in contact with the nerve. But in such scenario, because we know that physiotome, it do not cut Epizotome do not cut the soft tissues, because it works at a frequency of 25 to 50 kilohertz, which is far lesser than the frequency of soft tissue. But unlike in other conventional instruments like the handpieces or the aerator or I would say saw, they do not work on that some oscillating range. So what happened is they might to cut the nerve tissue or the gingiva or the I would say the cheek. So that's why it is very important that we use piezotomy. Obviously, when we use piezotomy, the surgeon or the implantologist, he also feel less stress and fear while working in such delicate area, right? So now you can see. I would say in this diagram, what basically you can appreciate is the arrow presently depicts the previous position of the mental foramen, right? Previous position of the mental foramen, and whereas the anatomical structure presented in the in the I would say oval thing is depicting the position of the inferior alveolar nerve, right? So what we have done is we have done the proper osteotomy and we have distalized the nerve here, right? I would say now in the remaining space we can put our implant, right? You can put your implant there and you can very well appreciate where we have distalized our inferior alveolar nerve, right? This is how we can and use a piezotome, and at the same point of time what we were needing is more, I would say, the uh, length of the implant so that it crosses the mental foramen groove and it better engages the 3 to 4 mm uh, bone after the mental foramen groove so that we get a good primary stability, and at the same point of time we should be very much sure we should be very much sure that if that our mental foramen is on the distal of our implant, right? So you can see it here, and this is how we are placing our graft and collagen membrane, which will act as a barrier, and you can very well appreciate uh, the placement of the graft in that mental foramen groove, which we were seeing in the previous slide, and it will allow the bone to form uh, uh, in proximity to the implant, okay, in proximity to the implant, and at the same point of time we are very much sure that if we cut the groove with the help of a piezotome, with the help of a piezotome, it's we are very much sure that at least we have not cut the inferior alveolar nerve vessels, right? So let us come to the, I would say, end of this uh, uh, webinar or lecture, that after doing so much cases, Rossetti, he claimed that the main advantages of this techniques, basically the nerve lateralization technique using piezotome, are that precision in performing osteotomy close to the nerve or the dura mater, right? So obviously, when we do piezotome surgeries, it is a very precise work, right? So when we do it, we have a very thin pencil shaped like inserts that allows the osteotomy to work in close proximity with the nerve, and at the same point of time not disturbing the nerve approximation, be it exon or be it anything or any particle, any structure of the nerve, right? So I would say minimal bleeding from soft tissues surrounding the osteotomy line would be noted. Obviously, which we have already seen due to the phenomena of cavitation. But we have noted that minimal bleeding would be or is noted when we cut when we see or when we do the procedure with the help of a piezotome, right? And when, and rather when we do the minimal when we do the uh, uh, nerve lateralization surgery using piezotome, what we have also noted that there is a minimal trauma to the bony part of the flap that is very much required for reconstruction, which you have already seen. If we do the surgeries using the nerve lateralization or using the piezotome, then obviously if we reduce the bony margin less, then obviously the reconstruction part, considering the graft and the membrane, would also be required in a very less quantity. Then we can anytime note that the minimal trauma would be there that is required for the reconstruction, right? So here we come to the end of our webinar. In case of any queries or in case of any questions during this webinar, you feel free to ask, or at any point of time you can message in the chat box so that we can understand that, and or if you feel like that you want to drop me message post this webinar, then I'm leaving my number and the mail addresses in the chat option so that in case of any issues or queries regarding the implantology and physiotome, or rather, I would say, uh, in oral and maxillofacial surgeries, I would be ready to help. Okay, I have left my mail address as well as the contact number. If still everyone have its doubt regarding the lecture, they are more than welcome. So, there's a question from Krishnakant Pagwar. Sir has asked that when will you prefer, okay, when will you prefer the conventional birds over denser bird after its splitting? So I would say whenever uh, uh, you feel that uh, in and around the bone need to be condensed and corticalized. You can see which I am showing you in this slide. You can note that whenever we want that bone to be compact and corticalized, okay, then in such cases you can use your tensor. Basically, I would say your question, other than the ridge split, I would say you can use it in the indirect sinus lifts, okay, where already the bone is of very less mineralized D3 D4 type. And at the same point of time, I would we will be discussing that in the coming, I would say, lecture on next of our webinar series. There we have already used the denser burr. In that scenario, sir, you can see it here. I have used the last burr, right? I have used the last burr and condense it using the denser burr. So in such scenario, we can use it. We can use our denser burr, right? Okay, so and there's another question from Krishan Kant sir, and he has asked, what I prefer, ridge expansion over ridge splitting, and my answer would be, so why not both the options? First the splitting and then the expansion. Uh, First split it, uh, which I would say we'll see it here. First split it and then slowly and slowly expanding it to the dimension of our desired length of our no, sorry, desired width of our implant, right? So in such scenario, you can use it. Sir, you can see in this diagram where I have expanded after splitting. I have expanded it. This is this is you can see the thickness of the bone here before splitting and after splitting and expansion. It looks like this. Okay, it looks like this. So you can convert it here, and now we have very good advancement and in instruments and other bone remodeling units, be it densa or be it piezo, and they work wonders and can we can put an implant in such rare atrophic ridges like this. Okay, and there's another question from Pratik Shah sir, and he has asked that what is the difference in two models of piezo from woodpecker? Sir, I would say the piezo electric unit. I have two units. One is the first the basic one, and the other is the third tip. And they have more tips in the form of more, I would say, tips in third version, and at the same point of time they have perio tips now, the extraction tips for the extraction tips, and then now they have also included the curettage tips as well. So in such scenario, where there we can use, and obviously the financial part. For that, you need to consider contact the woodpecker guys. They will rather tell you further, right? So in case anyone is interested in getting the articles or videos or PPT of the same, they can drop me a message, WhatsApp or mail. I'll be more than uh, uh, happy to help you out. Okay. Uh, so in case anyone is interested in getting the articles or videos or PPT of the same, they can drop me a message, WhatsApp or mail. I'll be more than happy to more than happy to help you out. Okay. Uh, so in case anyone is interested in getting the articles or videos or PPT of the same, they can drop me a message, WhatsApp or mail. So let us complete this webinar, and we'll be meeting in the next webinar. This is rather, I would say, would be the most interesting part. Sinus lift, where we have put an implant in 1 or 2 mm width of the implant and thickness of the height implants. There we would be seeing it in the upcoming lectures.